Welcome, everyone. My name is Julia Gorey. I'm with the Division of Policy and Assurances here at OHRP. I also am the Executive Director of the Secretarial Advisory Committee on Human Research Protections. So I wear a couple of different hats here, but I'm delighted to be here today to be able to speak to you about human research protections involving prisoners. Now, the talk today has several objectives. Firstly, I'm hoping to briefly describe the history of the subpart, then explain the regulatory interpretation of prisoner, explain the permissible categories of research at 45 CFR 36 and the Epidemiological Waiver, describe the requirement for a prisoner representative in IRB review, describe the requirement for certification to OHRP, and the process for that certification. So with that said, let's get started with just a little bit about the history. Now, like mental hospitals or orphanages, prisons have long offered researchers a captive population with subjects who live in very predictable circumstances. Inmates at a given penitentiary may eat the same thing at the same time, sleep the same hours, and generally are not lost to follow-up. Too often, however, in the past, prisoners haven't had a choice about participation in research. We begin talking about Subpart C history as you might guess, in Germany in World War II. The Nuremberg doctors' war crimes trial in 1947 cast a very harsh public light on prisoner research. It's interesting to note that bioethical regulations for human experimentation did exist in pre-Nazi Germany. They were issued by the Reich Minister of the Interior in 1931. And these guidelines included the basic concept of informed consent and regulated both therapeutic and non-therapeutic research. The 1931 guidelines were never annulled, yet they utterly failed to curb the abuses that were to occur later in the concentration camps. The defense of the Nazi doctors rested on the argument that their procedures mirrored standard Western medical practices, and the defense submitted ample documentation to prove its point. One such work was the book Experiments on Human Beings in World Literature by Dr. Erich Halbach. Now, this book describes, among other experiments, studies involving 800 convicts from 3 American prisons. They were artificially infected with malaria. The defense stated that out of 53 printed sources that were quoted, quote, 17 state that the subjects consented. In 36, the matter was not mentioned in any way, and in several it appeared that the subjects might not have presented themselves willingly, unquote. Therefore, they argued the question was not whether human experimentation was acceptable, but whether it was a crime. Well, obviously, the prosecution condemned the experiments. 16 of 23 doctors were convicted and 7 hanged. The Nuremberg Code, which emerged, embodies many of the basic principles governing the ethical conduct of research today, the first of which is the voluntary consent of the human subject. One of the studies specifically cited in the defense of the Nazi doctors was the Statesville Penitentiary Malaria Study. This was conducted in the 1940s by the U.S. Army and the State Department. The background is that malaria and other tropical diseases ravaged the U.S. war effort in the Pacific, and there was the urgent need to develop new treatments. This was particularly so, given that the largest quinine factory in the world had fallen into Japanese hands. 441 prisoners volunteered for this study, and the experiments gained considerable media attention and praise at the time. The volunteers were lauded as patriots. A committee formed by the Nuremberg prosecution justified Statesville as conforming to the highest ethical standards of human experimentation. And despite the Nuremberg Code, research involving prisoners continued on this side of the ocean through the 1970s. As evidence, we'll look at some of these facts. 14 of the 16 companies were conducting phase 1 drug testing using prisoners. 9 of 14 drug companies used prisoners only for phase 1 testing. And the Jackson State Prison had the largest research operation at that time in the country. By 1974, the Pharmaceutical Manufacturers Association estimated that about 70% of approved drugs had been tested on prisoners. Many of these facts came to light in 1973 as a direct result of an exposé published by journalist Jessica Mitford. Just 6 months after the Tuskegee syphilis study first became public, the Atlantic Monthly published Mitford's 1973 account of pharmaceutical experiments that were being conducted in U.S. prisons. A researcher had confided to her that prisoners are fine experimental material and much cheaper than chimpanzees. In the 1998 book Acres of Skin, Alan Hornblum published an account of research conducted on inmates at Philadelphia's Holmesburg prison from the 1940s to 1974. Now, most of these experiments involved the effects of chemicals on skin. This is where retin A was developed. But they also included military trials of LSD and other mind-altering drugs. The title is a reference to dermatologist Albert Kligman's reaction on first seeing hundreds of prisoners when he entered the prison. All I saw before me were acres of skin. It was like a farmer seeing a fertile field for the first time. Well, the result of these and other abuses was a very highly charged public atmosphere surrounding human subjects research in the 1970s. In the U.S., regulations protecting human subjects became effective in 1974. These regulations raised to a regulatory status what had been NIH's policies for the protection of human subjects. Those were first issued in 1966. President Nixon signed the National Research Act in 1974, which created the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research. Now, most of you probably know that the National Commission would later, in 1979, release the Belmont Report. But first, in 1976, it released its report on research involving prisoners. In that report, the National Commission said, there are 2 basic ethical dilemmas concerning the use of prisoners as research subjects. First, whether prisoners bear a fair share of the burdens and receive a fair share of the benefits of research. And secondly, whether prisoners are, in the words of the Nuremberg Code, so situated as to be able to exercise free power of choice. That is, whether prisoners can truly give voluntary, informed consent to participate in research. The Commission's report formed the foundation for the 1978 regulation, Additional Protections Pertaining to Biomedical and Behavioral Research Involving Prisoners as Subjects, which eventually became codified as the current Subpart C. So that's enough about history. Now let's actually talk about the regulatory interpretation of a prisoner under Subpart C. This is the first determination that an IRB has to make. The definition is found at 303C, and it says that a prisoner means any individual involuntarily confined or detained in a penal institution. It includes those persons who are sentenced under a criminal or civil statute, individuals detained in other facilities by virtues of statutes or commitment procedures which provide alternatives to criminal prosecution or incarceration in a penal institution. And it includes individuals detained pending arraignment, trial, or sentencing. I just want to pause again over that second bullet because this category, this bucket, really includes the majority of subjects who are prisoners in HHS funded or conducted research involving prisoners. So, does your study involve prisoners as defined in Subpart C? I'd like to just make a couple points with this slide. Beginning on the left, Subpart C applies in conjunction with the other subparts. Of course, the IRB also has to apply Subpart A. Unfortunately, very often in HHS-conducted research, the IRB is also going to be applying Subpart D. Now, for some subjects, the IRB may be assessing protections for co-occurring disorders, such as Ted Kaczynski, who was diagnosed as a paranoid schizophrenic. I'm often asked about subjects such as Martha Stewart, who experience some sort of electronic monitoring, whether it's an ankle bracelet or otherwise, subjects who are limited to home detention. This is really a gray area in Subpart C, and determinations are usually made on a fact-specific, case-by-case basis. I'd encourage you, if you have these sorts of situations, to call OHRP. Often the criteria that is used to judge whether or not the subjects are prisoners is whether or not the subjects are truly being detained, or whether or not the monitoring device is used simply to gauge the subject's whereabouts and to limit where the subject can go. Finally, I wanted to point out, with my picture of Richard Hansen here, that some subjects who might be in a federal prison will have other restrictions placed upon the research that they can participate in. The Federal Bureau of Prisons has its own restrictions, generally limited to minimal risk or therapeutic research that has been determined to be in the subject's best interest. Finally, you should also be aware that in some states there are laws that prohibit or completely limit the types of research that can be done involving prisoners. So although many people, when they first think of a prisoner, will think of someone who's perhaps classically in a prison such as Alcatraz, I have to say that that's generally not the type of prisoner that we see in HHS conducted or supported research today. Since the Common Rule was developed, the landscape of research activities has changed dramatically, and it's been accompanied by a very marked increase in the volume of research. So these are images much more commonly associated with research involving prisoners today. You see here co-occurring disorders, drug and alcohol abuse and treatment, images related to reintegration into the community from some sort of prison or step-down facility. There's lots of research that involves utilization of some sorts of social or medical services. There is research involving prisoners that also involves homeless populations and HIV/AIDS populations. Now, why are these subjects prisoners? Most commonly, these subjects are prisoners because they're adults or juveniles who've been placed in some sort of drug or alcohol treatment as a term of parole or in lieu of sentencing, either at enrollment or at some point after enrollment. So with all that said, who is not a prisoner under the regulations today? Who is not a prisoner? You're not a prisoner if you voluntarily have entered treatment because there's no detention. You're not being confined. You can leave. So if you voluntarily entered some sort of substance abuse treatment, you are not a prisoner. If you've been released from prison and are in some sort of a halfway house or some facility that serves the same point, same purpose as a halfway house, you are not, you're not a prisoner. You have to be a little careful with the words that you use because the terms change markedly state to state and jurisdiction to jurisdiction. If you're a person who's court adjudicated to attend non-residential treatment programs as an alternative to incarceration while living in the community, you're not a prisoner under Subpart C. So let's pick that apart a little bit. What that means is that if you have subjects who are living at home or someplace in the community and they attend, for example, drug treatment on Monday, Wednesday, and Thursday from 2 o'clock to 5 o'clock, but then they go back home to the community, they are not considered prisoners under Subpart C. However, If those persons have been court-ordered to attend residential drug treatment facilities, then they will be considered prisoners under Subpart C. Lastly, if subjects have been civilly committed due to a danger to self or to others, they're not considered prisoners under Subpart C. Now, the second determination that the IRB has to make is, does the research fall under one of the categories of permissible research outlined in Subpart C? Subpart C has 4 categories of permissible research described in Section 306. There is also one other very narrow category that we'll talk about in a minute, but these 4 are the main ones. The first 2 are minimal risk categories. Category 1 is a study of possible causes, effects, and processes of incarceration and of criminal behavior. I can tell you that this is a very large category of HHS-funded research that I see coming into OHRP. This includes a lot of research that's examining transitions to the community, different kinds of social service programs, anything that's associated with often drug abuse, HIV, because those conditions are so integrally associated with the criminal justice system. Therefore, they're viewed as being processes of incarceration and criminal behavior. So category 1 is very large. Category 2, study of prisons as institutional structures or prisoners as incarcerated persons. This is a fairly small category. Again, it is minimal risk. Here, for example, you might be looking at meals served in prisons or a smoking cessation study that's directed just of prisoners. Category 1 often includes subjects who at recruitment were not prisoners, but later on at some point in the study, perhaps while the intervention is still going on, perhaps during follow-up, these persons become prisoners. I should note here that the definition of minimal risk in Subpart C is slightly different than that you find in Subpart A. Minimal risk is a probability and magnitude of physical or psychological harm that's normally encountered in the daily lives or in the routine medical, dental, or psychological examination of healthy persons. I just want to stress here that the point of reference is healthy, unincarcerated persons. That should be the baseline, healthy, unincarcerated persons. And this is just to show briefly a typical sort of study that would come in for certification. I realize that this is somewhat dated. I should have replaced it with a more current slide. But this is just a very common type of NIDA study examining brain recovery in drug abusers. Category 3, research on conditions particularly affecting prisoners as a class. Now, the regulations provide these examples: vaccine trials and other research on hepatitis, which is much more prevalent in prisons than elsewhere, and research on social and psychological problems such as alcoholism, drug addiction, and sexual assault. Now, Category 3 is a very, very small category because it requires a secretarial consultation before the research can proceed. We'll talk a little bit more in just a moment about this secretarial consultation. We haven't had a secretarial consultation in approximately 10 years. Studies that come in for certification that have requested this designation have been appropriately able to be placed in other categories or redesigned so that they would not trigger this need. Finally, we have Category 4. Category 4, research on practices, both innovative and accepted, which have the intent and reasonable probability of improving the health or well-being of the subject. Now, first I want to note that there's no risk limit on either Category 3 or Category 4. These are not limited to minimal risk. Category 3, again, requires a secretarial consultation. Category 4 might require a secretarial consultation if it triggers the control group clause. And let's talk just for a minute about that. The category goes on to say, the study may proceed only after the Secretary has consulted with appropriate experts, including experts in penology, medicine, and ethics, and published notice in the Federal Register of the intent to approve such research. If, I'm going to go back for just a moment, if the control group clause is triggered. If you are assigning subjects who are prisoners to a control group, and for OHRP's interpretation, that includes standard of care, treatment as usual, or services as usual, the certification will trigger the need for the secretarial consultation. On the other hand, if prisoners are being assigned to several arms, active intervention arms, that are not considered standard of care, the study will not trigger the need for a secretarial consultation. I should also note that this need is not required for studies that aren't conducted or funded by HHS. There is the expectation, however, in those circumstances that the institution is going to convene some sort of internal equivalent panel. So with that, I'm going to pause and see if there are any questions. Okay.
I think we can move it on.
Okay, there will be another opportunity at the end for questions. So I had mentioned previously that there was a very narrow fifth category of permissible research involving prisoners, and that's the Epidemiologic Waiver. This was crafted in May of 2003, and it does function as a very narrow fifth category. It's designed for studies in which the sole purposes are to describe the prevalence or incidence of a disease, and disease is very broadly interpreted, or to study potential risk factor associations for a disease. The study has to be minimal risk, and prisoners can't be the sole focus. Now, the thing to really remember about the Epi waiver is that the institution still has to certify to OHRP. It's a little bit of a misnomer. People hear the word waiver and they think they don't need to certify. You do need to certify. So I also wanted to point out where you can find the Epidemiologic Waiver on our website. It's a little bit buried, but this is a good opportunity to show you some useful features on the website. If you're at OHRP's homepage and then go down to vulnerable populations, you will see a document labeled Prisoner Research Certification, and this will outline the basic materials that have to be sent in the certification package. And there, down at the bottom, you'll see the link for the Epidemiologic Waiver, which will outline the criteria for it. It is narrowly construed. It was constructed originally for CDC-funded research, but historically, disease has been interpreted rather broadly. Now, a few other protections I want to discuss that are built into Subpart C. The IRB review must include a prisoner representative. This is Section 304 of Subpart C. It says at least one member of the board shall be a prisoner or a prisoner representative with appropriate background and experience to serve in that capacity. Who exactly that person is really up for your institution to determine. We frequently at OHRP will get questions as to whether or not a certain person has the experience and expertise. But it's really not for us to decide that. It's really for your institution to decide that. And it's going to vary depending on the type of prisoner research that you're reviewing. Keep in mind that whoever you choose, they have to be a full voting member listed on the IRB's roster. This person cannot be a consultant. They have to be a full voting member. Now, there are a couple of different ways that you can handle designating the prisoner rep for purposes of the roster. And and these are also outlined in our prisoner FAQs. You can either have two rosters, and one of them include the prisoner rep, and then your minutes would designate at the beginning which roster was being used. If you list only one roster, then you can merely asterisk the person who's serving as your prison representative. However, I also want to note that the prisoner representative can be an alternate for a voting member. The prisoner representative can be an alternate for a voting member. Again, I just want to stress that this person cannot be a consultant. Now we get to the other determinations that are required of IRBs as part of Subpart C review. And to a large extent, these are really the meat of the protections afforded by Subpart C. These are the criteria that have been embedded in the subpart in order to reflect the Belmont's principles of justice, beneficence, and respect for persons. And they're, they're found at 305A, 2 through 7. Just to go through them very briefly, the first determination that the IRB has to make is that the study actually fits into one of those criteria of research. And the study might not. You should bear in mind that Subpart C was written in a fairly conservative atmosphere in terms of human experimentation involving prisoners, and was really constructed on what I'll call a but-for basis. But for the categories that are designated in the subpart, research involving prisoners cannot occur. The second element that the IRB has to discuss and review is whether there are possible advantages associated with the research participation, and assuring that they're not of such a magnitude that the prisoner's ability to weigh their risks is impaired. Risks of the study must be commensurate with risks that would be accepted by non-prisoners. The selection of subjects within the prison must be fair and immune from arbitrary intervention by prison authorities or prisoners. The information that's presented must be in a language understandable to the subject population. There must be assurance that parole boards will not consider research participation in parole decisions, and prisoners should be informed in advance that participation in the research will not affect parole. And finally, there needs to be adequate provision for follow-up care. Now, I want to note that in many cases, these criteria may simply not be relevant for the research that you're reviewing. In many cases, there won't be a prison, quote unquote. There won't be a parole board. The landscape of research, again, has really shifted from the time that these regulations were first promulgated. If that's the case, when you're sending in a certification to OHRP, you just need to note, pardon me, you just need to note that those criteria were not relevant. And then at 305C, you do find the certification requirement itself. The institution shall certify to the Secretary that the duties of the board under this section have been fulfilled. So now let's look at exactly what that certification looks like. It's really a big loop. The IRB does its review, and it makes its Subpart C findings. And of course, this is before there's been any intervention or interaction involving prisoners. The institution sends the research certification package to OHRP. OHRP makes a determination regarding whether or not the category was appropriate. Sometimes OHRP will determine that the IRB simply chose the wrong category, and it will recategorize it. OHRP will send a determination letter back both to the institution and to the funding grant officer. That should turn on the money. If the money has not already been released, that letter from OHRP will release the bar and turn on the money for the study. Now, if a subject becomes a Subpart C prisoner after enrollment, the study has to stop. The study has to be reviewed by the IRB under Subpart C, certified to OHRP, and OHRP has to go through the same process that the study falls into one of the categories. If, however, the IRB chair determines that it's in the best interest for a prisoner subject to remain on study prior to there being that Subpart C review, the guidance does allow the chair to make a best interest determination, and the IRB should certify as soon as possible, notably generally we say within several weeks. So what's different about Subpart C? Well, the exemptions don't apply, okay? They simply don't apply. People often ask where this comes from. You might have noticed that there's a footnote in Subpart A, and this is in footnote 1. The exemptions just don't apply to Subpart C. Again, you have to have that prisoner representative anytime Subpart C research is being reviewed. That's not just for initial review. It's for continuing review and amendments. The study has to fit into a 306 category or the Epi waiver. You have to, the institution must go through this certification process and wait for a response back from OHRP before starting the research. This is an important point. Subpart C is triggered regardless of when a subject becomes a prisoner, regardless of whether the subject is a prisoner at enrollment or whether the subject becomes a prisoner at some point downstream. Again, whether or not interventions are still going on or whether it's merely for enrollment. Anytime a subject is a prisoner, Subpart C is triggered. Lastly, the emergency waiver of informed consent is not permitted with prisoner research. Just a slide answering some questions for institutions who might wonder where their approval is if it hasn't come back as quickly as they would like. Most certifications are processed within 2 weeks, but many do require a back and forth, so I would just stress these points. Be sure to include contact information. It's frequent that certification requests will actually not include either phone numbers or email addresses. So just be sure to include contact information, the FWA number and IRB number of your institution, the date of the Subpart C review, the current protocol and consent and assent forms. That's not all protocols and consent assent forms, but the current ones. The name of the funding program officer, the category determination, the grant title, and the grant number. Finally, I want to point out some resources that are available on the web, the prisoner FAQs, the guidance document from 2003, and my phone number. We do try to be user-friendly. I handle a great many of these certification requests, but we also have other staff at OHRP that handle them as well. We're happy to try and answer any and all questions regarding this subpart. And with that, I'll stop and see if there are any further questions.
And Julia, while we're waiting for raised hands, I did have one question. So when we're talking about multi-site protocols, which is what we do in the CTN, when the submission occurs for prisoner certification, that can happen at the central site or the central node on behalf of all of the sites working on that particular protocol, correct?
Yes, it can. There has to be certification reflecting all engaged parties, but that can happen a couple of different ways. Depending on IRB authorization agreements and arrangements that are made. Either sites can certify separately, or there can be simply one site that the other sites are relying on that provides a certification.
And Sabrina Poole had a question. Please go ahead and ask.
So we have a prisoner or a released person from prison who is going into some sort of treatment service, let's say addiction service or parole.
Right.
So if we're doing a study where we wish to do a study using those persons newly released from prison, are they still going to be considered Part C?
If you are recruiting the subjects while they're still in prison, even though the study is going to really be occurring after they've been released, Part C is triggered because you're doing that informed consent and recruitment while they're in prison. I've seen it both ways. If you are doing your recruitment after they've been released and they're living in the community, then Subpart C is not going to be triggered.
Okay, so if they're out of prison and we're doing the consent part, then we don't have to file a Part C?
You don't, although I would comment that given the nature of many NIDA studies, many substance abuse studies, even if you're doing your recruitment when the subject is out of prison, if the nature of the study is such that you can expect there's going to be a high percentage of recidivism, the IRB can choose to certify under Subpart C prospectively. Otherwise, once you get going with that study and you find that your subjects are back in jail or back in prison, you have to stop. At least you have to stop any interaction with them. The rest of the study could proceed, but you can't have that interaction or intervention with the subjects that are now back in prison if you haven't done the Subpart C review. So in those cases, the IRB can really choose to do it either way. You can wait and do your Subpart C review once your subjects are in prison, and you can place your bets and see whether or not you're going to have that occur, or you can do it a priori. You can do it on the front end and certify in advance.
Now, if that person is on some sort of long-acting medication, for instance, are you allowed to make sure that they're safe? I mean, you said no contact. Are we allowed to make sure that they're safe ongoing until we get the Part C? Or is it just hands-off?
No, there can't be any research interaction or intervention. So, you would get into issues of confidentiality and privacy if you're accessing the prison to try and determine whether or not that person was, symptomatic, what kind of reactions they were having in prison. In those circumstances, I would encourage the institutions to certify ahead of time.
Okay.
Great. Thank you, Sabrina. There is also a question from Scott Provost in the chat. Does the definition of prisoners include individuals confined to county-level jail separate from a state-level prison?
Yes.
That was simple enough. Great.
Yes.
Scott, please speak up if you need more detail or more clarity there.
The definition covers whether it's a local prison or jail, county prison or jail. The level of the jurisdiction really doesn't matter. The only caveat, as I pointed out, is once you get to the level of a Federal Bureau of a Prison, generally there's other restrictions that are going to apply to federal prisoners. But it applies across the board, whether we're talking misdemeanors, felonies, and regardless of whether we're talking about jails or prisons.
Right. And does that satisfy your question, Scott?
Yes, it does. Thanks.
Fabulous. We have Eve Gelstrom, who's raised her hand. Eve, go ahead and present your question or comment.
Hi, Julia. Thank you so much for presenting to us today. I'm at the Clinical Coordinating Center, and I wanted to follow up on Tracy's initial question about the multi-site.
Right.
And just so you're aware, with the multi-site, it's typically also each site may have one, sometimes more than one, but may have one IRB. So do you need to see the IRB Subpart C application for each of those sites with their IRB letter, or you just need to see the initial one and it goes for all the others? And do you also need to see all the informed consents for each of the sites?
Typically what we see in those, it varies enormously. It really does. But typically in those situations, the lead site will certify. If the other sites have deferred the IRB review to that lead site, I've been aware of differing informed consent documents. If that were to be the case, then yes, those different consents should be included in what's sent to OHRP.
Okay. Because I'm thinking most of our trials, if it's multiple sites, there are multiple IRBs, usually at least one per site.
Right.
And so they will probably have each site, because it's different PIs, they'll have different
and very
investigators.
often I will get individual certifications from each of those sites.
Okay. That's predominantly how we've done it, but I just wanted to see if there's another way.
More often the way than not. That seems to be the model that is used most frequently.
Okay, that's good. And when I read the Subpart C and in the description of the Category 1 through 4, I have to tell you, when I read that language, it doesn't speak to me about what our research is, because it's usually talking about research about prisoners or research about prison, and it's like our research is drug use.
I know. And that's why I really encourage you to just kind of think more broadly, and the notion of this. A prisoner with sort of the ball and chain from the HHS perspective is just somewhat antiquated. Desks here at OHRP, it overwhelmingly is some type of substance abuse research. Overwhelmingly NIDA, NIAAA, NIMH. Involving co-occurring disorders with, some type of mental illness, some type of HIV. These populations that have this very close reciprocal nature with the criminal justice system. And that's why when you look at Category 1, 306 Category 1, which says study of possible causes, effects and processes of incarceration and criminal behavior, when you hit that word causes, you can stop right there, because OHRP will interpret substance abuse, mental illness, HIV, because of this close reciprocal nature with the drug abuse. We'll interpret those conditions to be causes of incarceration and criminal behavior, and therefore it fits into Category 1, if it's minimal risk.
Okay. Yeah, because typically, what we think about is, whether it's recruiting people who are not recruiting, it's follow-up. So typically we see Category 1 being for follow-up with prisoners and people who become prisoners after they've joined the study, after they've already been recruited. And then we see Category 1 and we think of that as being Category 4, predominantly being used when someone is being recruited as a prisoner.
A lot of social behavioral research fits into 1. Category 4, I can tell you, is more often used for biomedical research, but most social behavioral research will fit in Category 1.
Okay. And then one final question, and I'll let Tracy move on to other folks. If we are starting to look at maybe doing some registries and things, would that epidemiological waiver, or that Category 5, would that be potentially if we're looking at registry studies?
It depends. You get back to that pesky word disease, right? So maybe. I have to give you a very hard maybe. Okay.
We'll have to have you look at the protocol, and you can determine.
Yeah, call me. We'll talk.
Okay. Great. Thank you.
Yeah, registries can be a little difficult to handle.
Okay. Thank you, Eve. I'd like to open the line for Frankie Kropp. Frankie, go ahead.
Hi. Thank you again, Dr. Gorey, for your expertise. I would like to return back to the discussion where you were talking about the relative merits of obtaining prisoner certification before the study starts versus waiting for someone to become a prisoner.
Right.
So I just want to clarify that if you are going to plan on discontinuing contact with someone while they are a prisoner, you would not necessarily need certification. Is that correct?
Yes, that's true. You know, Subpart C is very temporal. It applies only if your subjects are prisoners there and then. So it may be possible in some circumstances to not incur Subpart C if you're able to have all of the interventions and interactions occur strategically while the subjects are not in a prisoner status.
So just to follow up on that, once the prisoner is, let's say the prisoner is only a prisoner for, maybe a couple of weeks. Right. That frequently happens. They go to county jail, they're in for 30 days, they come back, and they still have time in their duration of the study.
Right.
Once they are no longer a prisoner, you could then resume data collection.
Right.
But what about, because a lot of times the data that we collect, like on a timeline followback, for example, or an ASI, some piece of that is retrospective. Would you then, once they are no longer a prisoner, be able to collect this retrospective data covering the time?
Yeah, you can. So long as they're not a prisoner right now, then their Subpart C is not going to be invoked.
Okay, so I could ask them, while you were in prison, what did you use on day A, B, and C?
Yes.
Okay, great. Thank you.
Thanks, Frankie. I'm sure that helps a lot of people in our studies.
I really want to thank everyone. I'm sorry for having a frog in my throat for the last half of the study, but I do want to stress that, I do try to answer questions daily and be user-friendly with the community that's doing this kind of research. It's a fairly small community, which is nice. I think there's a lot of you out there that I probably know relatively well through calls and emails and communications. And I really respect the work that you're doing and want to try and help in any way that I appropriately can. So please feel free to pick up the phone or to email me.
Thank you, Julia. We really encourage more folks to come in from the institutions like OHRP and NIH to address the group, because it helps all of us with the conduct of these studies. So thank you for coming, and I thank all the participants for being here and those that pose questions, because it helps all of us. Now, last announcements. I'm going to send out a post-webinar survey, so I'm going to encourage all to participate in that, and welcome you all back on November 19th for the discussion on family involvement in substance use disorders and mental health treatment and research. We will post this presentation once I've had an opportunity to edit it on the CTN Dissemination Library's website, where individuals will be able to invoke the training and go through the materials at a more convenient time as well, and those that missed it. So please spread the word, because this information is very important. Again, thank you, Julia, for coming.
Absolutely.
And that will end our presentation. Thank you, everyone. Goodbye.